Dr. Tibi began practice in Phoenix, Arizona, and became managing partner of Phoenix Cardiac Surgery and chief of cardiothoracic surgery at Good Samaritan Medical Center in 1996 until 2007. In 2007, he was recruited to start the Open Heart program at Yavapai Regional Medical Center in Prescott, Arizona, and is currently chair of the cardiovascular department there. Dr. Tibi has had a long interest in patient blood management and has been developing PBM programs throughout hospitals in Arizona. He lectures both nationally and internationally on PBM and is a past president of the Society for the Advancement of Patient Blood Management and lead author of the 2021 STS SCA AMSECT SABM update to the Clinical Practice Guidelines on Patient Blood Management. Please join me in welcoming Dr. Tibi.
Thank you very much. It's a pleasure to be here in frigid Atlanta. And I'm going to have to talk pretty fast. I've got to make this in 15 minutes or so I can get you out on here on time. Here are my disclosures. These are the learning objectives that have to do with patient blood management, kind of a practical guideline to patient blood management in cardiac surgery. So let me first start out with a question. Whose role is it to facilitate patient blood management in cardiac surgery? Well, I can tell you that in primary care, anemia is vastly undertreated. In fact, just this weekend, for my 93-year-old mother was feeling weak and tired, went to her primary care physician. He said everything was fine. She's just getting older. And I said, okay, and went and saw her labs when I visited her just before I came here, and her hematocrit's 33. And I asked her, did the doctor say anything about anemia or iron or treatment of anemia? No, he said I was just fine getting older. That's how bad it is. Admitting physicians oftentimes never even seen the patient preoperatively. They usually are maybe see the patient actually right before surgery, but at that point, there's only limited amount that they can do. After cardiac surgery, my intensivist, who is greeted with a patient who's anemic and bleeding profusely, also has a limited amount of things that they can do to treat this patient. So it really comes down to the surgeon, because patient blood management spans the full spectrum and needs to be practiced, if possible, long before admission. Because really, we can get almost most patients through without needing a transfusion if we have time to treat them appropriately and we're doing all the things that we need to do. I was fortunate enough to be part of the 2021 STS SCA AMSECT SABM update to the clinical practice guidelines on patient blood management. 4 specific things that were very different from the 2011 is that, as opposed to the original ones being by the Society of Thoracic Surgery and the Society of Cardiovascular Anesthesiologists, they also included the Perfusion Society, AMSECT, as well as the Society for the Advancement of Patient Blood Management. The 2011s were the guidelines for blood conservation that was changed to the guidelines for patient blood management. We adopted the 4 major tenets from SABM, which Dr. Shander already spoke about, and that we included the treatment of the no blood patient or the Jehovah Witness patient as a guideline on how to treat and how most of these patients, what the nuances of treating patients who are witnesses. So importantly, like I said, blood conservation yielded to the broader term of patient blood management that incorporates not only the need to conserve blood, but more importantly, take into account the assessment of the liquid organ, which blood is, as the vital entity in taking care of the surgical patient. So I'm going to talk about some of the more important concepts within these guidelines, and I've separated into preoperative, intraoperative, perfusion interventions, and postoperative recommendations. So in the preoperative, I'd like to highlight these, and one that Dr. Shander just talked about, in that the assessment and treatment of preoperative anemia. Now, this is only a Class 2A recommendation, but I'm going to talk about that a little bit more to show you that all patients that are going to cardiac surgery can in fact become high-risk patients, which is a class 1 indication to treat patients who are high risk with all pre and post-operative things that we can do to treat patients for patient blood management. We also talked about the cessation of P2Y12 inhibitors, of which most patients are on. In 2021, we divided it into ticagrelor, clopidogrel, and prasugrel and talked about a certain amount of days. But today, point-of-care testing for these through platelet evaluation studies is probably more in line because, as we know, 15 to 30% of patients on these platelets inhibiting drugs may be under or over responders. The treatment of NOACs with reversal agents and, like I said, informed consent. Dr. Shander already showed this graph, but what it is, it shows that, as you were already told, that patients do worse if they are anemic or transfusions, and those that have anemia and transfusions do the absolute worst. So the class 1 level A recommendation is that a restrictive perioperative transfusion strategy is recommended in preference to a liberal transfusion strategy. In that preoperative identification of high-risk patients should be performed, and all available pre- and perioperative measures of blood conservation should be undertaken in this group. Now, this is a class 1 level A, and referring to what I just told you before, that was a treatment of anemia, which is a class 2A recommendation in the 2021 guidelines, as we know that all patients that undergo cardiac surgery can certainly be deemed high risk, especially as they lose blood. And therefore, in my estimation, all these patients, the treatment of anemia should be a class 1 level A recommendation, because in this study, we showed that over half of patients can be treated with iron because they are either non-anemic iron deficient or have anemic iron deficiency. Only 1/3 of our patients are neither non-iron deficient nor non-anemic. So there is a great opportunity to treat these patients preoperatively. Anemia, as mentioned, and transfusion are both strong predictors of major morbidity and mortality, and the cumulative effect of anemia and transfusion is even further. EPO and iron can be administered, and even a couple of days before surgery with high doses of EPO. And what we do at our institution is, as soon as I see a patient in the office for elective surgery, either elective coronary surgery or an elective valve surgery, that patient at that point is immediately, after they've seen me, is immediately sent to the lab for blood work and iron studies. Those iron studies if they come back and it shows that the patient is anemic or iron deficient, they are then sent to our virtual anemia clinic, and the people in that clinic will call the patient, tell them that they are anemic or iron deficient, tell them what they may or may not know about anemia or iron deficiency, will then treat the patients prior to surgery, all the time coordinating with myself as far as the timing of surgery. So most of the patients that I get that are not emergent are well prepared for surgery. Intraoperative recommendations, intravenous fibrinolytic agents is a class 1 level A recommendation, and viscoelastic testing or algorithms for goal-directed transfusion strategies that incorporate viscoelastic testing is class 1. Red cell salvage, which was in the previous guidelines, remains a class 1 because it's still unfortunately underused. Topical fibrinolytic agents, there's a fair amount of evidence in the orthopedic literature that there's significant improvement in bleeding with topical fibrinolytic agents, and it's a class 2A. Prophylactic FFP, direct reinfusion of shed blood, are class 3, which means they should not be used and they are harmful to the patient. And we did address topical hemostatic agents in those guidelines. Nevertheless, it was difficult to come to some kind of recommendations because the literature is all over the place and not great literature on each of these agents. Cardiac surgery is the poster child for bleeding. We're taking a patient and we're doing everything we can to make them bleed. We're operating on a sac of blood. We cool them down to lower levels of temperature. We greatly anticoagulate them, and then we take their entire blood volume and put it through a machine that destroys the platelets and absorbs the clotting factors. In addition to that, many of these patients may have a pre-existing coagulopathy, and as mentioned, many of these patients may be on antiplatelet or 10A inhibitors. So what I'm saying is that if you're going to look at bleeding and patient blood management, cardiac surgery is the poster child. Like I said, the goal-directed transfusion algorithms, which incorporate point-of-care testing, such as viscoelastic testing, are Class 1 recommendations. In many institutions around the country, I've talked to institutions where they have viscoelastic testing, and either they use it or they sometimes use it, or it's sitting there either in the OR or in hematology, and they're not using it. But when you look at treating a patient, an actively bleeding patient, time is of the essence. With regular lab tests such as PT, PTT, and platelets, once you're greeted with significant bleeding, you get those lab studies, you send them out, and obviously most of the time the surgeon won't wait for the lab studies to come back. They'll start with the cheapest, probably FFP, then they may give cryo, et cetera, all waiting for the study to come back. It might take an hour and a half to an hour and a half for the study to come back. It shows that borderline fibrinogen is reported from the lab. Then they call for the cryoprecipitate. Probably takes another 30 minutes to get it from the blood bank. And then now it's 2 hours later, and you're treating the patient here, where this is what you're treating here. So who knows what you're treating, because the coagulation scenario will have changed significantly. Whereas if you have viscoelastic testing, most of the machines will give us a rapid diagnosis within 10 to 15 minutes. If you decide that you wanted to give purified fibrinogen, you're now treating the patient within less than 30 minutes of the bleeding situation. But if you wait for the cryoprecipitate, it's maybe 40 to 50 to 60 minutes. But the goal here is you're treating situation in real time. These are the current viscoelastic testing devices. We actually use the Quantra, which is this one right here. They both give you these kind of graphs. And what we do is we take a study before surgery, on bypass, and after surgery. And if the patient is bleeding, if the patient's not bleeding, we get few false positives and few negatives, but if the patient's not bleeding, obviously we don't treat. If the patient is bleeding, then we have a much better idea of why the patient is bleeding, and we will treat that patient specifically with goal-directed therapy and continue to treat the patient until the bleeding is stopped and or the Quantra has normalized. Like I said in the guidelines, which we discussed hemostasis, topical hemostatic agents, and there are multiple ones here on that are available in every OR. The one thing that I find difficult to understand is that there's all kinds of different bleeding. There's bone bleeding. There's bleeding from raw surfaces, like in a redo operation. There's bleeding from specific sites, needle holes, etc. And their patients may they may have an intact coagulation system or non-intact coagulation system. So all of those things dictate what specific agent you will use, whether it's an active agent, a passive agent, or a combination of both. So the point here is that these agents, these topical hemostatic agents, have different properties, and they should be used in the appropriate setting for the appropriate type of bleeding. 4 perfusion interventions, including RAP and reduced priming volume, once again are Class 1. They were included in the 2011. Nevertheless, since they are not universally used, we included in the updated guidelines. Acute normal volemic hemodilution has received a lot of attention in the literature recently. And I can tell you that if it's done appropriately and part of an overall patient blood management care package, it is, I think, very useful. And then there is this combined strategy between anesthesia and perfusion management, MIECC. Postoperative recommendations, like we talked about, a restrictive transfusion strategy is Class 1. Allogeneic red blood cell transfusions for hemoglobin of greater than 10 or use of hydroxyethyl starch is a Class 3 indication, therefore not being used. I'd like to top it off with this study, which may answer or help answer Dr. Sloan's question before. So this was a very interesting study simply because of the magnitude. And what these authors did is they took the entire 10 years between 2010 and 2020 of the STS database. They isolated, they took out over 2.1 million encounters of either isolated CABG or aortic valve replacements. Of those, approximately 40% received transfusions, over 847 patients. They had 1.3 million patients that did not receive a unit of blood. They took a quarter, the best propensity matched 206,000 patients that received no units of blood, the best match to those that received 1 unit of blood, and compared them over approximately 30 different variables. And what they found was that most morbidity, including stroke, sternal wound infection, prolonged ventilation, hemodialysis, reoperation for bleeding, and operative mortality, was significantly less in those patients that received no units of blood versus those that received 1 unit of blood. And yes, it's a retrospective study, but the sheer size and the ability to match over 200,000 patients. When you think about, well, how many patients did I give 1 unit of blood versus no units of blood? What kind of difference can I make? Could that patient that got 1 unit of blood not have received any blood and still been okay? And most of the time, I would say in my practice, I would say yes. So the old mantra was, why give 2 units when 1 unit will do? And I suggest to you, why give 1 when none will do? And that is achievable by using patient blood management as a total care package. We start in the preoperative arena with assessing the patients for anemia, making sure that their anticoagulation, that their coagulation system is up to snuff. We care coordinate with the people around us that help us in the virtual anemia clinic. And then we've got multiple things that we can use both preoperatively, intraoperatively, and postoperatively. And in this situation, I think that we can take care of our cardiac patients, even some of the very sickest patients, without giving any transfusions whatsoever. And at the very least, you're saving a valuable resource. So I want to thank you very much. I'm sorry I condensed that 30-minute talk into 15 minutes.
Thank you so much, Dr. Tibi. Does anybody have a question? Okay. I know Dr. Gersh has been waiting to ask this question.
Hi there, I'm one of the cardiothoracic surgeons. I'm Karen Gersh. I had a question that kind of relates to both of the talks. So nationally, there's about a 13% patient population that comes in through the ER to the cath lab to surgery. Here at our hospital, it's probably pushing 30, maybe even higher than that.
I'm sorry, I can't hear you.
And so in the United States, about 13% of patients who present to the hospital come through the ER to the cath lab to the OR. We have about a 30+% rate of that here. So these patients are not receiving any preoperative care whatsoever. And it behooves us from an administrative perspective for a short length of stay. What are you doing at your hospital for these patients who are coming in with anemia. A lot of our patients are coming in with this anemia. They're coming in at a single event. They cannot go home. They have to stay for their surgery. So are you advocating to say, pump the brakes on how quickly we get them off to surgery, and there's a statistical difference in the money saved, because we have to talk about money, and those patients who stay longer and who have preoperative anemia management than the ones that are treated postoperatively with transfusion?
Sure, that's an excellent question, and I believe every cardiac surgeon around the country deals with this for length of stay, oftentimes it's the cardiology pushing it. The patient's had, a 70% left main for 5 years, and now they have to go tomorrow or tonight, no matter what the situation is. And that's a difficult political situation to deal with, but what you have to always do is what you feel is best for the patient, obviously. There's studies will show, and there's a recent study that shows that preoperative preparation of the patient is as important, if not more important, in decreasing postoperative morbidity and mortality. In the worst of circumstances, like I said, you can give EPOs starting before. You can give large doses. I've given 80,000 units in one dose, as well as a gram of iron. And at the very least, that will help the patient recover. But sometimes you just have to move ahead. So you do the best you can. But if at all possible, if you have some time to give the patient a day or two before surgery, after they've had their, especially if they've had an acute infarct or a STEMI, they definitely will do better postoperatively as far as hemodynamic function if you give them 2 to 3 days to cool off. But in that time, you can treat the patient. You can make sure that they're not on anticoagulants that will cause them to bleed more. You have to do what you can for the patient, but in preparing the patient from all standpoints, I believe that your cost will be less down road than before. A patient with postoperative renal insufficiency or postoperative coagulopathy or multiple transfusions is going to cost you more than if you waited a day or two in either the pre-cardiac unit or the ICU.
First of all, thank you to both of you for coming. These were really nice talks on an important topic, and we appreciate you being here. You're obviously enthusiast for restricted transfusion policies or practices. When is it okay to give a transfusion? I'll flip the card on you. When can I order up a pack of red cells and not feel bad about it, in your opinion?
Well, I guess that's a personal issue of how bad you feel about asking for a unit of red cells. So obviously there are times when a patient is severely anemic and has hemodynamic instability and has active bleeding, and you have to transfuse the patient. And I'm not telling you never should transfuse a patient. I am telling you that you should do whatever you can in whatever time you have to avoid a transfusion, because that is a complication. Transfusion is a complication of whatever is going on. It's not necessarily your fault, but it is a complication.
If you develop renal failure, the last thing is a transplant. But when it comes to blood health, when the blood is not healthy, such as anemia, we start off with a transplant, which is a transfusion. However, we think it should be your last resort, and that the first thing is to see how is the patient doing clinically. If the patient is doing okay, and we know what the diagnosis is in terms of the anemia, what is the cause, is it iron deficiency, it's inflammatory, whatever the reason is, we apply those therapies immediately. We don't wait. And if the patient is still not doing well, we come down to the list of now we're going to try to do the transplant to see if it improves health. I will tell you that many times we just give the blood and expect the hemoglobin to go up, but we really don't check the delta in terms of the clinical improvement of patients. We assume that it's going to do that. So again, great question, but we're not enthusiasts of restrictive. We're enthusiasts about modifying risks of the patient, and two, trying to put into practice the idea that blood as an organ should be respected as one with all of the different diseases, and that a transplant, which we think a transfusion is, should be on the list of therapy, which would come last, not first. I don't know if that helps.
Thank you so much. It looks like we have two more questions. We'll take these last two questions. Is it okay? Okay.
Have you been able to look into the mechanism for 1 unit of blood causing unfavorable complication rates? Does it have anything to do with the fact that blood is an organ and you might get immunologic changes?
Yeah, definitely. I mean, blood is an organ. It will cause a significant amount of immune response. We have multiple studies that show how it increases infection rates. So I think the mechanism is multifactorial, and the evidence is there. Arya, do you have anything?
But think of it, that blood supply, whether it's in the United States or anywhere in the world, can be exposed to a new organism. And that organism takes us time to identify it in the blood system. And if that organism gets transmitted through transfusion and causes deadly disease, it's going to take us a few months now to actually identify and remove the risk from the population. What is not talked about, which is the largest risk of allogeneic transfusion, is immune modulation. We don't transfuse the healthy, we transfuse the sick who already have a modulated immune system, right, from their disease. Now we're presenting them, whether it's a single unit or more, with blood from another person. They may be ABO compatible, but the number of proteins that are in that unit from the donor clearly overwhelm the ABO system. And that reduces the patient's ability to fight infection, whatever it is, also in terms of other morbidities. This has been in the literature now for decades, but is ignored by the medical community as a risk of transfusion. So immune modulation is on top, all of the others are on the bottom, but don't forget, we're always, every day we wake up, there could be something in our blood system that we don't know of, so we have to be cognizant of that too.
Thank you. So, I'm sorry, we're over time. We have one final question, and feel free to talk after the program. We're going to finish this last question. We have clinical.
I think in our area, we have probably 40 to 50% of our patients are going to be anemic, and I think it might do with our region. You know, we have a high carb, high fat diet, and in y'all's research, have they done a research project that shows anemia related to that and how you can prevent that with cardiothoracic surgery? Because anemic, iron, proteins, just wondering.
Iron deficiency anemia is the #1 cause of anemia worldwide. Iron deficiency. Iron deficiency anemia is easy to diagnose. Iron deficiency anemia is easy to treat. And iron deficiency anemia, if done correctly, can be cured in 95% of patients. Nothing else in medicine compares to that, so it's simple. And guess what? Iron is a nutrient. So diet is clearly essential for blood health. Now, another area is that, I don't know if you're aware of this, but vitamin D deficiency and iron deficiency anemia are tied together. Many iron deficient patients worldwide, right, and I said is the #1 cause, have also vitamin D deficiency. Even in countries such as in Southeast Asia, as an example, where the majority population, say, are Muslims, and the women are covered during a sunny day, right? So they're not getting the vitamin D they need from the sun. That vitamin D is associated again with a worse iron deficiency anemia. So the whole issue of nutrition, whether it's cardiac surgery patients or any patients, is vital to this. But if we don't make the diagnosis first of the anemia and try to look for the source of the anemia, the nutrients that are required, as you know, B12, folate, there are tons of these different areas, and now I mentioned vitamin D, which a lot of people are not aware of. We need to look at that in conjunction when we see the patients in terms of their nutritional status and address that, because the anemia may not actually be able to be effectively treated if we leave some of these nutrients unaddressed. I hope that answers.